welcome to Healthy Happy Hour. I'm Angela Berg, nurse practitioner here with Cure for the Kids. We are continuing our series where we're talking about pediatric rheumatologic disorders. Particularly, we're focusing on arthritis and trying to answer the questions we've gotten from you on what you need to know and what you want to know about how arthritis happens in kids, how is it different in adults. And today we have Dr. Joshi with us, and we're really going to focus on two things. We want to talk about the specific types of arthritis in children because they're very different than our grandparents' arthritis that we're used to growing up knowing about, and also what kind of joints are involved with children because they can often be very different in appearance than an adult onset arthritis. So welcome, Dr. Joshi. Thanks for joining me again for another dive into juvenile arthritis as we really try to focus on let's start by talking maybe really, well, I'm going to actually defer to you. Is it better to talk about the types of arthritis first and then really kind of talk about the joints, because then we can link what types might affect more areas?
Yeah.
Okay.
Yeah, well,
Let's start with that.
It's a pleasure to be back, Angela. And I think I might talk about, I can tackle both of those questions simultaneously.
Perfect.
Because it would be easier in that way to understand.
Okay.
So the official classification of the different types of arthritis is called as the ILAR or ILAR classification, and there are 7 subtypes of arthritis. But a better way to understand in my experience is if we don't really go into the nitty-gritties of the official classification, but rather think of arthritis in children as different clusters. And that's when the correlation with what types of joints in the body are being involved becomes relevant.
Oh, I like that. That makes a lot of sense.
Yes, yes. So let me start out by naming those 4 clusters.
Okay.
In the order of how common they are.
Okay.
The most common cluster is something called as seronegative arthritis, and sometimes that is also called as early onset arthritis, and that is the commonest type of arthritis that we see in children. And there are sort of 2 different flavors of that particular type. One is called as oligo-JIA, and the other is called as seronegative poly-JIA. And what defines this particular class is that is not a very aggressive type of arthritis. It is very mild. It happens in younger children. It involves fewer joints as opposed to the next category, which I'll talk about next, the seropositive one, which is not milder. It is way more aggressive. It typically happens in older children or teenagers or young adults, and it can involve not a few, but many joints. And those 2 right there, the seronegative and the seropositive types of arthritis are the most common ones that we see. Now let me talk a little bit more about oligoarthritis, which is, as I mentioned, a type of seronegative. And then before I do that, let me actually explain what do I mean when I say seronegative. So
good.
Yeah, so it has to do with autoantibodies, and antibodies are protective proteins which are floating around in our blood, which help us fight viruses and bacteria. But here, what we are talking about are something called as autoantibodies, which means these are the proteins which were supposed to fight the bacteria and the viruses and are being produced by our own immune system, but now they are attacking our own joints. And the 2 most common types of autoantibodies that we see in arthritis is RF or rheumatoid factor and CCP, which is a close cousin of the rheumatoid factor. If we see the presence of either of these 2 autoantibodies when we do a blood test, that becomes seropositive arthritis. So all of our newly diagnosed children, when we diagnose arthritis, we make sure that we test for these 2 autoantibodies, and they distinguish the seronegative arthritis from the seropositive arthritis. Now going back to the oligoarthritis, which is the commonest type of arthritis by far that we see in children. It tends to affect children who are young. It typically tends to affect only one or less than 4 joints by definition, knee being the most commonly involved joint, followed by the ankle, followed by the wrist or the elbow. And that is the type of arthritis which is the highest risk of also affecting the back of the eye, which we call uveitis.
I'm going to pause you for a moment. I want to clarify there that too, I think it is a common myth that people think it has to be both knees, not just one knee or one elbow. So that I think is an important distinction to say with oligoarthritis. It can be few joints and they don't have to be symmetrical.
It is, no, absolutely, and more often than not, what we see is asymmetricity, which means only one side of the body, one joint being involved, and then the other. And that also reminds me of a very common teaching point, because younger children can have a little bit of chubbier looking joints, so it might be hard for a medical student, for example, to say whether the joint is swollen or not. And that's when we say, look for asymmetricity. Look if one joint looks bigger or more swollen than the other.
Or chubbier.
Or
than
chubbier than the other. Yes, yes.
Yeah.
And I'm talking about toddlers or preschool age children there. But yes, we rarely see both the joints being involved, at least to begin with. So one knee, one ankle, one wrist, one elbow being swollen more than the other would be a common presentation.
Great point, great point. So then the difference between oligo and poly would be the number of joints by definition?
That is correct. And the magic number there is the number 4, which means that oligoarthritis would never involve a 5th joint. By definition, there has to be 4 or less than 4 joints involved all over in the body in order for us to classify that type of arthritis as oligoarthritis. Polyarthritis is related to oligoarthritis, and I'm talking about the seronegative poly here, but it's a little bit more aggressive, and it can actually involve a number of joints, 5 by definition, but much more than 5. So as you can see, there is a spectrum. We are moving from oligo, which is the mildest type of arthritis, to seronegative poly, which is somewhere in the middle, to seropositive poly, which is the most aggressive type of arthritis, so much so that it has a cluster of its own. So sort of kind of wrapping and going back to the 4 clusters which I mentioned. One is the seronegative, which is oligo as well as the seronegative poly. The other is seropositive, or the technical term would be rheumatoid factor or CCP positive polyarticular GIA. Let's talk a little bit more about that cluster. That is the cluster which is characterized by involvement of the small joints of the hands. That is also characterized by symmetricity. So when a lot of the grandparents, because autoimmune diseases run in the family, many of the grandparents, when they talk about their fingers being deformed by rheumatoid arthritis, they are talking about this particular type of arthritis, which tends to affect, in our case, older children and teenagers. It tends to affect bilateral hands, small joints of the fingers, and it tends to be more aggressive because of the presence of those 2 autoantibodies, the rheumatoid factor and the CCP, and this can actually cause joint damage. It can erode into the superficial layer of the joint. It can also cause finger deformities, and that's why we have to be a little bit more aggressive when we treat this arthritis, as opposed to the seronegative cluster.
Right. We also look at those seropositives as risk to doing permanent damage to the bone with erosions to the surface. of the bone tissue, and can lead to a lot more of that inflammatory process in the bone,
Yes.
which can lead to, we had talked earlier about bony overgrowth that can cause loss of function of a joint, as well as that permanent change to the synovium. So truly, then what we're talking about here is that seropositive is a much riskier, needs us much more aggressively to address, recognize, and treat those to prevent long-term complications.
Right, and a good segue into that would be answering the question on why we are doing labs when we are trying to diagnose arthritis. Arthritis is a clinical diagnosis. We are not trying to diagnose arthritis on labs, but we are trying to classify it. That's when we test for the RF and the CCP to gauge on how aggressive this type of arthritis is. And that also leads me to an important point of radiographs or x-rays. We always want to do x-rays of the joint which is involved in JIA, not to diagnose arthritis, but to see if any of those markers of high risk or aggressive disease activity present. And what we really look for is something called as erosions on x-rays, which means that the immune cells are trying to bite into or chew into the superficial surface of the bone where it forms the joint. And that's why we do labs, and that's why we do x-rays on all our patients when we make a diagnosis of JIA.
Absolutely. So I want to pause here for a moment, and then there are two other clusters that you want to talk about of arthritis. So I want to keep these in bite-sized segments so that we can all get the most out of them. So don't go anywhere. We'll be right back, and we're going to talk more about the other two clusters that are a little less common of pediatric arthritis, and we'll be right back. Hi, welcome back to Healthy Happy Hour. I'm Angela Berg, nurse practitioner here at Cure for the Kids Foundation. I am with Dr. Joshi joining me as we continue our exploration and answering your questions that you've asked us about juvenile arthritis. And there are two more clusters that are a little less common. We spent time on our previous segment about our most common, so let's explore those other two less common but still important for us to understand that juvenile arthritis can attack many different joints, not just knees or ankles, and it can be sneaky in its presentation, so that it's an important part of our evaluations as rheumatology providers. Let's talk about those other two clusters.
Yes, let's talk about them. So the other two clusters are something called as spondyloarthropathies and systemic JIA. Let's tackle the spondyloarthropathies first. Spondylo means the spine and arthro means the joint. So whenever we see arthritis, which in addition to the peripheral joints is also involving the spine, that becomes the big cluster of spondyloarthropathies. The three most common examples of spondyloarthropathies in children are: number one, juvenile psoriatic arthritis, which means that you may or may not have the associated skin condition called as psoriasis, but there can be involvement of peripheral joints as well as the spine. The second one is something called as ERA or enthesitis related arthritis. Many people might be familiar with the word ankylosing spondylitis, and that is an adult counterpart to the pediatric JIA subtype called as ERA. And just very quickly, enthesitis means inflammation of the soft tissue called as enthesis, which is where the muscles or the tendons join the bone. That part is called as enthesis, and if that's being inflamed, that's called as enthesitis. And the third category, which sometimes is recognized as a separate entity and sometimes is not, is something called as IBD associated arthritis. IBD stands for inflammatory bowel disease, which means that most of the children that have inflammation in their belly, ulcerative colitis or Crohn's disease, may have involvement of the joints, and some of them can have involvement of the spine in addition to peripheral joints, and that tends to be classified under the title of IBD, or inflammatory bowel disease associated arthritis. This big category is called as spondyloarthropathies, and as I mentioned earlier, the telltale feature of this cluster is involvement of the spine. And the last cluster here is something called as systemic JIA. And some people might be familiar with the adult counterpart called as Still's disease. That is a completely different disease which has far and few things in common with all these other types of clusters, because this is a systemic disease. And by which what I mean is, in addition to the joints or the musculoskeletal system, it can involve other end organs, most commonly the heart, the lungs, the liver, so on and so forth. So we tend to see systemic JIA as a completely different disorder, as a much more aggressive disorder, which has the potential or the ability to involve the entire body and cause inflammation and fever and rash and swelling of the lymph nodes, which is not the case with any of the other clusters.
Right. I think it's important that people understand part of our history taking is often any unexplained fevers, unexplained rashes. So those going together are often our clue into sometimes the body can be leaning towards developing these systemic kind of diseases and not fully evolve into it, and so it too can be sneaky. So it seems these patients, these kiddos either present sneaky, showing signs of it, or incredibly ill and hospitalized in the ICU.
Right. That's a fantastic point. Other way to look at the same point, or to better drive it home, is children who have JIA should not be sick. They should not be ill appearing. Of course, they have some joint problems and some joint swelling, but they should not come across as someone who has a serious systemic illness. And systemic JIA kids can look like that.
Absolutely.
And that's when the importance of review of systems and history taking is very important. You want to make sure you don't have any high-grade fevers, you don't have any rashes, you don't have any swelling of the lymph nodes, you don't have weight loss. None of this should be happening if you have those first three clusters of JIA, as opposed to the answer being yes to these red flags if you have systemic JIA.
Absolutely. Good point. So I'm glad we got in all of those clusters. I want to talk a little bit about what is different about us as a team here at Cure for the Kids, tooting our own horn, if you will. I'll toot yours because I adore working with you and feel like we are so lucky to get your expertise. Together combined, we come from very different teaching. I did the on-the-job doing some residency hours with CHLA once I discovered my love for rheumatology, which wasn't my intention when I became a nurse practitioner. And you chose purposely and went in and excelled and have gotten your ultrasound certificate and excelled in so many parts. I think overall there is our diverse expertise, our ability for ultrasound clinic with you, our commitment to expanding the outreach and availability of these services. And under that, I mean, we don't require a whole evaluation to be done before you come to us, because in the commitment to most efficient, effective way of getting to the root of what we need to do to make kids better, it's best if we just see them and do it all ourselves and do it quickly. And that being our commitment, but also our ability to do telemedicine, which I adore as a person who loves outreach and have done outreach with Cure for the Kids for so long. I adore that your passion for telemedicine has really helped us bring this to fruition. So talk a little bit about your vision for our team as we continue growing this rheumatology service, and what you see as advantages to how we work.
Thank you for listing all those really cool things that we are trying to do here, and I must say that I love working with you as well. And I agree with you that we are really trying to build not only standard of care, but state-of-the-art pediatric rheumatology program, which means that we want our patients and families to have access to what is considered cutting-edge pediatric rheumatology. And let me talk a little bit about ultrasound. Ultrasound is a modality which is very well positioned to serve the field of pediatric rheumatology because of so many reasons. Ultrasound is a modality which is super child friendly. There are no needles involved. There is no pain involved. There is no need of sedation. It can almost become a play when we are trying to explain of what arthritis is to younger children, because it is so visual.
I was going to say, I love what we've seen so far, as the kids love being able to see when you're rolling that probe over the joint, you're able to actually explain to them, and they are so engaged with you when they're doing that.
Right, right. Imagine trying to explain a 6-year-old what inflammation is. Mm-hmm. It's very hard. Mm-hmm. But once they look on the monitor of the ultrasound, oh, there is all that black colored fluid inside my joint and all this red looking extra blood flow appearing, it just becomes so much easier for them to comprehend mm-hmm. of what inflammation or GIA is. Mm-hmm. Also, our ability to do multiple joint scans at the same time,
right,
as opposed to an MRI, in which, because of the use of contrast, we are typically limited to just scanning one joint, mm-hmm. and there is an IV involved, and there is sedation involved, mm-hmm. and it just takes time for us to coordinate that service. Mm-hmm. So and because of all those reasons, another very common one that I must explain is the dynamic maneuvers. We have the ability to move the joint as we are scanning it to see if the fluid
right.
shifts around. So
yeah.
the benefits of ultrasound and its relevance to our practice cannot be overstated. But in addition to that, I think telemedicine is also something which we can utilize a lot more, because once the diagnosis has been made, for many of our rheumatologic illnesses, we don't necessarily need a physical exam at every visit. And I know that many of our families are visiting us from outlying areas in the state, and they have a very long commute mm-hmm. here. And they love the ability to connect with their provider, and sometimes they actually do a physical exam for us. Mm-hmm. Sometimes they move the camera and have us look at the joints or look at rashes. So it's very, very scalable and convenient and visual, and I personally think it is very, very underutilized. And I'm glad that we have a robust telemedicine program so that we can utilize the disseminability, but also the fact that patients don't have to travel and sit in a waiting room and be triaged. It's also very efficient.
I could tell you from the way that we were doing outreach before, it has been so impressive to me that even our provider time is utilized so much better. I'm not flying to Reno to see patients. Once we get an initial, we may still in the future need to do initials in these outlying areas, but we're able to reach so many more patients in so much less time when that travel burden is reduced. And I think that if COVID helped us with anything, it is telemedicine growth, and your experience in Arkansas before you came and the ability you were able to establish there with telemedicine has been such an advantage to us here.
Yeah, and maybe that's why our telemedicine clinic is our busiest clinic, because our patients and families love it. And very quickly, I also want to talk about a few more not necessarily minor, but pretty key important details that sets us apart. One is we do not have a wait list, which means we'll be able to see you right away. Number two, we do not require a lot of labs or imaging to be done in order for the referral to be made by yourself or your primary care doctor. We just want a clinical suspicion or any symptom that makes you concerned about, I might have a rheumatic disease. And number three, I think our passion for clinical pediatric rheumatology, and we are both really truly invested in this profession, and for us, we just enjoy it. It's just another day when we can go to the clinic and meet different families and try to see if we can help them in any way. And that's what brings true pleasure and joy and satisfaction in our lives. And I'm glad that we are almost like kindred spirits in that regard.
Absolutely. I think too we have such a common bond in not being afraid of integrative therapies, which I think in this day and age people want to try as much natural intervention as they can, and that is really difficult for a lot of healthcare providers to allow into their practice. In fact, we're so committed to it. In January, I'm going to do the integrative medicine certificate to add to our shared briefcase, if you will, of tools that we have. So I think we complement each other very well. There are things like my passion for chronic pain and developing that program, and you're so supportive of that program. A lot of times healthcare providers aren't able to support each other, I think, as well as we support each other, and our environment and mission, vision, values of Cure for the Kids is just such a whole perfect combination, I think, for us to really develop a rheumatologic program here for kids that really is expansive, not just traditional, isn't afraid of Eastern versus Western medicine, and putting all of our smart ideas together. I'm not afraid to ask you questions, you're not afraid to ask me questions, and I think us not being afraid to include parents and kids as we're in this together. We are all part of the team together. We're not afraid of any of your questions to ask us. There's no such thing as a silly question. I think all of that sets us apart as being a very different rheumatologic program, because rheumatology is not so widely available across the country. I think that makes us quite unique as we continue to build and already have a new provider, new physicians joining us. Dr. Paim, we're very excited about. She is a perfect fit. We're all birds of a feather, if you will. So I think that we are really positioning this service well to be within Cure for the Kids' mission and vision and growing specialty care for kids here in Nevada.
I completely agree, and I'm so glad that you added and brought up integrative medicine to our conversation. And I just love that word, integrative. What it means is that our job is to pick the best of both worlds.
Yes.
We are not really married to the idea of Western medicine or Eastern medicine. We are trying to ask the question, how can we help you? How can we help the patient? And if we find that there are modalities in either of these two different styles of practicing medicine which are applicable and safe and effective, we would make a case to utilize them, whether it is mind-body medicine, whether it is acutherapy, acupressure, acupuncture, whether it is aromatherapy. So we are really open and supportive of whatever modalities makes our patients feel better, whether Western or Eastern, and that's why we are trying to integrate the two. That's where the word integrative medicine comes into picture, and I'm personally a big fan of that model of medicine.
We live it, I think, both of us, and we share that in common as well, which makes that a natural fit for us to add it into our practice. So I really appreciate that part. So I hope that we've been able to answer the questions. I think we covered all of the questions that we've been getting online and in feedback on social media for parents. We hope you find it helpful. We will continue to do our work this way and continue our Healthy Happy Hour to evolve to being what our community needs. And you let us know what that is. And we look forward to seeing you next time. Thanks so much for being here.
It's a state of the national health.